Hello, this is Dr. Eric Simpson, Professor of Dermatology at Oregon Health and Science University in Portland, Oregon. Welcome to Geneva, and welcome to this educational activity focused on updates in atopic dermatitis treatments that were presented at the 26th European Academy of Dermatology and Venereology Congress, or EADV Congress, in Geneva, Switzerland.
The following audio is part of a certified educational activity titled Analyzing the Latest Evidence in Atopic Dermatitis, Clinical Updates from Geneva. Access the entire activity and complete the post-test at www.peerreviewpress.com/DAV. Downloadable slides and practice aids are also available.
Atopic dermatitis significantly affects the quality of life of patients, especially those with moderate to severe disease. The treatment paradigm for this condition is evolving rapidly, with the recent approvals of 2 new agents, Dupilumab and crisaborole, as well as other advances that were discussed at the conference in Geneva. At the last EADV, we witnessed the emergence of the biologics for atopic dermatitis. This year, I'd say, was the year of the JAK inhibitors. It was overall a very exciting meeting for many novel treatments for AD. Let's begin by discussing a large study of the epidemiology of AD in adults. Although usually thought of as a childhood condition, it was observed in a recent study that AD is prevalent across the globe in many adults. In this cross-sectional web-based survey, where web panel participants were unaware of the survey contents when they accepted the survey, thus reducing selection bias, prevalence estimates for AD were 4.4% in the EU, 3.5% in Canada, and 2.1% in Japan. This was one of the first attempts to define the burden of this disease across the globe, and found a very high prevalence in adults in many parts of the world. Let's now discuss updates and treatments that were presented in Geneva. We'll start with targeted biologic agents that inhibit extracellular cytokines, and then we'll move to small molecule drugs that target intracellular molecules that can be taken orally. Dupilumab is a monoclonal antibody that inhibits the alpha subunit of the interleukin-4 receptor, consequently inhibiting the actions of both IL-4 and IL-13. IL-4 and IL-13 are Th2, or more broadly, type 2 cytokines that mediate many of the pathological characteristics of atopic dermatitis, as well as asthma and other allergic diseases. Some of their effects in atopic dermatitis include promotion of itch, downregulation of filaggrin, and propagation of further inflammation. They can also lead to class switching for immunoglobulins and eventually trigger the production of immunoglobulin E, a key mediator in allergic disease. Dupilumab was approved in March 2017 for the treatment of moderate to severe atopic dermatitis in adult patients whose disease is not adequately controlled with topical prescription treatment or when these treatments are not advisable. This approval was based on positive results in multiple phase 3 studies. In the SOLO-1 and SOLO-2 studies, for example, Dupilumab monotherapy, which means without concomitant topical steroid use, showed significant efficacy in various outcomes, including the signs of the disease as measured by EASI and the symptoms of the disease, i.e. itch. Interestingly, this reduction in itch and eczema severity led to improved quality of life scores and even significant reductions in anxiety and depression symptoms. A separate study, the Liberty AD Chronos study, demonstrated the efficacy and safety for Dupilumab in combination with topical steroids. Significant effects were also seen in the signs and symptoms of the disease, as was seen in the SOLO studies, with slightly higher rates of improvement in the study because of the combination use with TCS. Importantly, Chronos also found that these effects continued over the course of 52 weeks of treatment. At the EADV, an analysis of the Liberty AD Chronos study was presented, evaluating the efficacy and safety of Dupilumab stratified by baseline demographics. Clinicians are often interested to know whether patients respond similarly despite their comorbidities, sex, weight, etc. Results demonstrated that at both 16 and 52 weeks, Dupilumab plus TCS achieved similar response rates as seen in the original analysis, regardless of age, sex, BMI, or prior history of asthma, allergic rhinitis, or food allergies. Patient-reported pruritus, often considered the most bothersome symptom of AD, was also improved in all studied demographic subgroups. In patients with a higher BMI, the more frequent dose of dupilumab did not make a difference. The safety profile was consistent with previous studies of dupilumab. Another novel analysis of Liberty AD Chronos that was presented at the EADV examined the effects of long-term treatment with dupilumab on CCL17 or TARC levels and IgE levels, as well as the relationship between baseline levels of these markers of Th2 inflammation and the treatment response. This study found that baseline demographics and clinical characteristics were balanced among the treatment groups, except for higher CCL17 and total IgE levels in the groups of patients receiving dupilumab every 2 weeks compared with the other two treatment groups. 87% of patients had elevated IgE levels, and 83% reported comorbid type 2 immune diseases, including asthma, allergic conjunctivitis, allergic rhinitis, and food allergies. Both dose regimens of dupilumab rapidly and markedly suppressed serum CCL17 concentrations. This effect was sustained in the dupilumab groups, and there was little to no change in the placebo group. The magnitude of suppression of CCL17 was greater at weeks 2 and 4, compared with the magnitude of reduction in EASI scores at those time points. So you can see this Th2 biomarker drop prior to clinical benefit. Serum total IgE levels gradually declined with both dupilumab regimens from week 4 to week 52, while there was a trend towards increase in the placebo group. A higher proportion of patients had normalized IgE and CCL17 levels with dupilumab compared with placebo at week 52. Dupilumab also significantly suppressed a wide range of serum allergen-specific IgEs compared with placebo after 1 year of treatment. Baseline CCL17 and IgE levels were weakly correlated with percent changes from baseline in EASI and peak pruritus scores at week 16 in both dupilumab and placebo-treated patients. Baseline levels of CCL17 and total IgE were not significantly associated with IgA 0/1 success or EASI 75 responses in the dupilumab groups at week 52, suggesting that this agent is effective regardless of those biomarker levels. However, response in the placebo group was higher in patients with lower CCL17 and IgE levels, suggesting that topical corticosteroids are less effective in patients with higher levels of these markers. The Liberty AD Chronos analyses presented at the meeting imply that dupilumab is effective in a wide variety of subgroups of adult patients with atopic dermatitis, including those with or without other allergic diseases. This is a significant finding, as many patients with atopic dermatitis have comorbid allergic diseases. In addition, dupilumab reduces IgE sensitization, both total and specific, and future studies should examine whether dupilumab therapy reduces other allergic diseases with continued therapy. In a late-breaking presentation at the EADV, the results of a new study, the Liberty AD CAFE study, were presented. This was a phase 3 study of adults with moderate to severe atopic dermatitis who were inadequately controlled with or intolerant to cyclosporin A treatment, or for whom this treatment is medically inadvisable. So the objective here was to evaluate the effect of dupilumab treatment in a more refractory patient population. 325 patients in Europe were randomized to receive either dupilumab 300 milligrams weekly with topical corticosteroids, dupilumab 300 milligrams every 2 weeks with topical corticosteroids, or placebo with topical corticosteroids. The primary endpoint of the study was the EASI 75 response rate, meaning the proportion of patients achieving a 75% reduction in EASI from baseline, as measured at week 16. The primary endpoint was achieved by approximately 60% of patients in the dupilumab groups, compared with 30% of patients receiving placebo, a significant difference. These results were very similar to the Chronos study results. These improvements were also observed in a subgroup that only included patients who were previously treated with cyclosporin. The mean percent change in EASI score from baseline at 16 weeks was approximately 80% in the dupilumab groups and about 47% in the placebo group. Significant improvements with dupilumab plus topical corticosteroids compared with placebo plus topical corticosteroids at week 16 were also observed for SCORAD, a more holistic scoring system that includes both signs of the disease and symptoms. Patients in the Dupilumab groups also experienced significant improvements compared with the placebo group in pruritus, quality of life as measured by DLQI, the EQ5D pain discomfort score, and the patient-oriented eczema measure, or POEM, which quantifies the illness as experienced by the patient. The differences between the Dupilumab groups and the placebo group were observed as early as week 2 for some of the outcomes. No new adverse events were reported in the study. Conjunctivitis was more frequent in patients who received Dupilumab plus topical corticosteroids, with an incidence of approximately 16% and 28% in patients who received Dupilumab weekly or every 2 weeks, compared to 11% for patients who received placebo plus topical steroids. Injection site reactions were reported in 11% and 4% of patients in the weekly and every other week Dupilumab groups, compared to 5% of patients who received placebo with TCS. Skin infections were reported in 4% and 2% of patients in the Dupilumab groups, compared to 8% of patients who received placebo plus TCS. The results of this Liberty AD Café study are meaningful because the study was conducted in a refractory patient population, patients who did not respond to cyclosporin, and these patients responded just as well as the broader population studied previously. There are also many patients who cannot tolerate cyclosporin or cannot take it due to contraindications. Moreover, it's not advisable to continue cyclosporin treatment for prolonged periods of time due to renal toxicity issues. Dupilumab represents a novel treatment option for these patients. While conjunctivitis may occur somewhat frequently, it is usually mild to moderate in severity and may resolve on therapy. Further work into understanding the etiology and optimal management of the conjunctivitis is needed. Next is Nemolizumab. This is a monoclonal antibody that targets IL-31, which is also known as the itch cytokine. 12-week phase 2 data have been published showing that Nemolizumab significantly improved pruritus at various doses in adult patients with moderate to severe AD. Data from a long-term extension of this study out to 64 weeks were presented in Geneva. The results showed that the improvements in the pruritus visual analog scale were maintained out to 64 weeks, especially in the 0.5 milligrams per kilogram and at higher doses. There were modest improvements in the signs of the disease and appearance of the rash. Concomitant use of TCS may be beneficial to strengthen the anti-dermatitis effect of Nemolizumab. No serious safety concerns were identified. The most common adverse event was nasopharyngitis. There were some concerns regarding dropouts, peripheral edema, as well as eczema flares in the treatment group, however. These results encourage further clinical trials of Nemolizumab in AD. Let's move on to discuss the potential role of Janus kinase inhibitors, or JAK inhibitors, in the treatment of patients with atopic dermatitis. These agents potentially have a wide application in dermatology and a variety of inflammatory conditions. Janus kinases are key mediators in the signaling pathway of numerous cytokines implicated in the pathogenesis of atopic dermatitis, which include IL-4, 13, and 31, tofacitinib, a JAK inhibitor approved for rheumatoid arthritis, and likely to soon be approved for psoriatic arthritis, has shown to be effective in a phase 2 study of atopic dermatitis using a topical formulation, confirming the potential role of these agents in the treatment of this disease. A variety of JAK inhibitors are therefore being investigated in this setting. Let's discuss the data for JAK inhibitors in atopic dermatitis, starting with baricitinib. Baricitinib is a once-daily oral JAK1/2 inhibitor that has recently been approved for rheumatoid arthritis in Europe and Japan and is under development in the United States. A phase 2 study examining treatment with baricitinib of adult patients with atopic dermatitis was presented at the ADV. After a 4-week run-in with TCS, patients were randomized to receive either placebo plus TCS, 2 milligrams of baricitinib plus TCS, or 4 milligrams baricitinib plus TCS for 16 weeks. There were significant improvements in the proportion of patients achieving EASI-50, a 50% improvement in EASI score from baseline, at week 4 with both baricitinib doses compared with placebo. These effects were maintained to week 16, achieving the primary endpoint, but were only significant for the 4 milligram dose at this time point. Significant improvements in SCORAD were observed at week 4 and maintained through week 16. Significant differences for SCORAD pruritus and SCORAD sleep loss were also noted at various time points. Some reductions in clinical disease scores were observed as early as 1 week with baricitinib. Although both doses of baricitinib showed significant improvement in patient-reported outcomes, the 4 mg dose was associated with faster onset of action and greater improvement compared with the 2 mg dose for some measures. Baricitinib had an acceptable safety profile in this study. Treatment-emergent adverse events that occurred at higher rates with baricitinib compared with placebo and were greater than 5% were headache, increased blood creatinine phosphokinase, which we see as a class effect with JAK inhibitors with no known clinical relevance, and nasopharyngitis. A late-breaking presentation of phase 2 data in a JAK1 selective inhibitor was presented at the ADV. Adult patients with moderate to severe AD and an inadequate response to topical treatment were randomized to receive placebo or 10, 30, 100, or 200 milligrams once daily. The primary endpoint was the proportion of patients achieving an investigator global assessment of clear or almost clear, with at least a 2-grade improvement from baseline at week 12. A significant greater proportion of patients receiving the 100 and 200 milligram doses achieved this response compared with placebo. 28% in the 100 milligram group, 45% in the 200 milligram group, and 6% in the placebo group. Rapid IGA and EASI score responses were observed with the 200 milligram dose. 64% of patients receiving this dose achieved at least a 4-point improvement in the pruritus numeric rating scale at week 12 compared with 26% of those receiving placebo. The improvement in pruritus with the 200 milligram dose was observed as early as day 2. Daily doses of up to 200 milligram for 12 weeks were generally well tolerated, although a gradual drop in platelet count occurred in this dosing group that recovered spontaneously over the course of the study. Next, we have JTE-052, which is a pan-JAK inhibitor under clinical development for the topical treatment of atopic dermatitis. A poster of a phase 2 study of adults with moderate to severe AD in Japan was presented in Geneva. Patients were randomized to receive this ointment at 0.25, 0.5, 1, and 3%, as well as the vehicle ointment or another control 0.1% tacrolimus ointment. These ointments were applied twice daily for 4 weeks. Prednisone could be used as rescue medication for disease worsening, according to the investigator's judgment. Patients in all of the JTE-052 groups experienced a significant change in modified EASI score from baseline, which was the primary endpoint, compared with the vehicle group. The improvements appeared to be dose-dependent. A rapid improvement of pruritus was observed as early as day 1 for the 3 higher dosing groups, compared with vehicle as well. All adverse events were considered mild or moderate in severity, the majority of which were mild. No serious adverse events were reported. No clinically significant changes in laboratory parameters or vital signs were reported. Clinical results were similar to tacrolimus ointment 0.1%, but with fewer side effects and burning. Taken together, these studies suggest that the use of JAK inhibitors in atopic dermatitis is very promising. If approved, these additional treatment options could provide an increased opportunity to tailor treatment to the needs of each individual patient. It's difficult to compare the efficacy of these JAK inhibitors, as the study designs were quite different. For example, in the baricitinib trial, the 4-week run-in with TCS and use of TCS throughout may have artificially restricted patients to more difficult-to-treat disease. However, these are still very relevant and exciting results, and we look forward to further studies. Other treatment classes are also being studied in atopic dermatitis. For example, Tapinarof is a first-in-class aryl hydrocarbon receptor agonist that inhibits specific pro-inflammatory mediators including IL-6, IL-17A, and eotaxin-3. It therefore has potential to improve both barrier and inflammatory effects. In a way, it's an old treatment coming back because it has the same target as the active compounds in TAR. The efficacy and safety of Tapinarof cream in patients with atopic dermatitis was investigated in a dose-finding study that assessed 2 different concentrations, 0.5 and 1%, and 2 different application frequencies, once daily and twice daily. Results of this study were presented at the EADV. This study included both adolescents and adults. The mean baseline value of IgA was 3.1 across all treatment arms, and the mean baseline values of EASI was 9.8 to 13.1 across all treatment arms, representing a population with moderate disease activity. The primary endpoint was the proportion of patients achieving an investigator global assessment of clear or almost clear, with at least a 2-grade improvement from baseline. Both the 0.5% and 1% formulations showed greater efficacy than vehicle. The 1% cream had higher efficacy than the 0.5% cream and had a quicker onset of action than both the 0.5% cream and vehicle. Reductions in pruritus were comparable across all active treatment arms. This cream was generally safe and well tolerated. Therefore, Tapinarof cream represents a potential novel non-steroidal topical therapy for the treatment of atopic dermatitis. Additional studies are warranted to further discern the efficacy and safety of this treatment. Now let's talk about potential treatments for chronic pruritus, which is defined as an itching sensation lasting at least 6 weeks. Chronic itching may significantly impact quality of life at the same level as chronic pain and is associated with sleep disruption, depression, anxiety, and even suicidal ideation. Disrupting the itch signal by NK1 receptor antagonism has been demonstrated to reduce itch intensity. A phase 2 trial of serlopitant, an oral NK1 receptor antagonist, was presented at the meeting. Adult patients with chronic pruritus, unresponsive or inadequately responsive to topical steroids or antihistamines, were randomized to receive placebo or serlopitant at 0.25, 1, or 5 milligrams once daily. Serlopitant 1 milligram and 5 milligram were superior to placebo in reducing pruritus at 6 weeks, as assessed by the VAS itch score. Mean DLQI scores were lower than placebo in all treatment groups at all post-baseline visits, and significance was achieved with 1 milligram at week 4. The differences in the distribution of subjective global assessment ratings of pruritus severity relative to the placebo group favored therapy, but were not statistically significant. By week 4, a majority of patients in the treatment groups had mild itching or no itching, compared to those in the placebo group. Almost all treatment-emergent adverse events were mild or moderate in severity. No clinically meaningful trends in laboratory abnormalities were present. One patient receiving 0.25 milligrams had a clinically significant change in an ECG at visit 6, which was considered mild and possibly treatment-related. Since pruritus has a significant impact on patients with atopic dermatitis, serlopitant could be a potential adjunctive treatment option for these patients. However, it's unclear whether treating itch without treating the rash would be sufficient for clinicians and patients. In conclusion, data presented at EADV confirm the efficacy of Dupilumab and highlight that the efficacy is sustained in the long term. Furthermore, Dupilumab is effective in various groups of patients, including those with refractory disease and those with and without comorbid allergic conditions. Also, there are a multitude of additional agents with novel targets, including JAK inhibitors and aryl hydrocarbon receptor agonists, being studied for atopic dermatitis. It is exciting to have new and emerging treatment options with various mechanisms of action and routes of administration that do not have the safety concerns associated with traditional therapies. Well, that ends our discussion for today. I hope you found it informative and useful. Thank you very much for participating in this educational activity focused on updates in atopic dermatitis presented at the 26th EADV Congress. Thanks.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerviewpress.com/DAV. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals.